Good evening. This is Dr. Gregory Nicola. I'm the Vice Chair of Economics for the American College of Radiology and the Chair of the MACRA Committee. I want to thank you all for joining us tonight. We've done a number of different educational items regarding the MACRA legislation passed in 2015. They've generally concentrated on one of the limbs of MACRA, that was the merit-based incentive payment system. Tonight, we decided to bring you educational materials from two experts, Dr. Ryan Lee and Dr. Dan Durand, who are both participants of alternative payment models and radiologists. They will begin the presentation shortly. Just a couple of housekeeping items. We will be taking a Q&A from the audience. You can either raise your hand and we can unmute your line, or you can type in the chat box and we can read your questions as they come in. Tonight, I also will have a co-moderator, my esteemed colleague, who's the Vice Chair of the MACRA Committee for the American College of Radiology, Dr. Lauren Golding, who Lauren and I will also moderate the session and ask questions in addition to the audience questions. So I don't want to take time from our presenters, so I would like to start off by first introducing Dr. Ryan Lee. Ryan is the Vice Chair of Quality and Safety at the Einstein Healthcare Network. He's the chair of his local MACRA committee at Einstein. He's a friend and a colleague. I've worked closely with him on MACRA. He's been our go-to expert on one part of the APM pathway that he'll go into a little bit. He's going to start with a broad overview of what the alternate payment model pathway and what exactly an alternate payment model is, and the pathway itself inside MACRA. And then Dr. Durand, our expert in accountable care organizations, is going to dive into recently revised rules for the Medicare Shared Savings Program accountable care organization models. So without further ado, I'm going to let Ryan go ahead and take the mic here.
Thanks so much, Greg. I appreciate the introduction. I'll start off with a basic overview of the alternate payment models track of the QPP, or the Quality Payment Program. Before we get into the Quality Payment Program, I'd like to start off with a background of how we even came here. And to do that, we have to go all the way back to 2015, and more specifically April of 2015, when the Medicare Access and Chip Reauthorization Act was enacted and signed into law by then President Obama. And it really did two things for the purposes of our discussion today. So it ended one form of physician payment, and namely that was the end of the sustainable growth rate. And as many of you probably know, that was a kind of complicated formula in which the conversion factor, or essentially the way physicians were paid, was accomplished. What happened was it did result in multiple negative adjustments for physician payments almost every year that required a yearly fix by Congress. But it did end that in 2015. So at the same time, since that form of physician reimbursement was now ended, it forced CMS to come up with a new plan, and that is namely the Quality Payment Program. The Quality Payment Program is broken up basically into two arms. The first arm is called the Merit-Based Incentive Payment System, or MIPS, which has been discussed, as Dr. Nicola had mentioned, on several prior broadcasts. Today, we're going to focus on APMs, or the alternative payment models. And there's really several forms of alternative payment models. I'd like to first start with the advanced alternative payment model and work my way backwards, because there are some in-between models between the advanced APM and MIPS. So what is an advanced alternative payment model? Well, there's a very simple definition, but in reality, it's really not that simple, but it does boil down to three basic things. You have to use certified EHR, so you have to have electronic medical records that has been certified by CMS. Number two, you have to have payment services which are based on quality measures that are similar to those used in the merit-based incentive payment system. Finally, you do have to bear significant financial risk, which is defined by CMS. So those are three basic criteria in being defined as an advanced alternative payment model. What are some of the benefits for the advanced alternative payment model in general? Well, there are two main benefits. The 5% bonus, in other words, if you are an advanced APM and you qualify, and we'll talk about what it means to qualify in a moment, you will get a 5% bonus on the year prior to payment, your Medicare B spending. The other big bonus is that you are excluded from MIPS, and that is actually a larger thing than maybe some would realize, only because it is quite logistically challenging to get MIPS properly filed. So that's a big bonus. There are some smaller benefits as well. One is that starting in 2026, and maybe not such a small benefit, but a pretty significant benefit, there may be an upward adjustment in the physician fee schedule for those facilities that are functioning as an advanced APM. So for 2019, what are some of the advanced APMs? There's several more besides this list, but these are some of the major ones. There's the PCI bundled payment system. We have the comprehensive ESRD, only the two-sided risk. Same thing with the oncology care model, which is two-sided risk. MSSP track 1+, 2, and 3, and Dr. Duran will talk about the changes in MSSP in which these tracks have actually been overhauled with a new system. And then some of the earlier next generation ACOs and the comprehensive care for joint replacement. So these are what are defined as advanced APM. However, just because you are an advanced APM does not necessarily mean you would get those benefits, which I talked about, including the 5% bonus and the exclusion from MIPS. You actually have to be what they call a qualified participant or a QP. And what that means for the purpose of 2019 is that you have to demonstrate one of two things. You either have to show that 50% of your billing through Medicare Part B payment is through an advanced APM entity, or that 35% of your patients are through an advanced APM. So only when you meet one of these two criteria will you then be able to take advantage of the benefits, including the 5% bonus payment. Starting in 2019, however, there is an additional way that you can become a qualified participant, and that's this new all-payer advanced alternative payment model. And so if you don't qualify as a qualified participant via either the 50% of Medicare payments through the advanced APM or the 35% of Medicare patients that are through an advanced APM, you may still qualify as a qualified participant by combining your advanced APM through CMS and other payer advanced APM. So if you meet a minimum threshold, which is a lower threshold than the 50% or this 35%, and you combine it with other payer advanced APM, you may still be able to take advantage of the 5% bonus through being an APM. Now this can only be done through sending this through to CMS, and they will make that final determination. However, there are criteria that they will use to make this determination. So starting in 2019, there will be two ways that you can become a qualified participant. Let's now move to the in-between of being advanced APM and straight up MIPS. There is something in between that's called MIPS APM, which is basically a modified MIPS sort of track. Just like with the advanced APM, there are several criteria, and the basic criteria to qualify for MIPS APM scoring is that, one, you have to participate in an APM under agreement with CMS. Two, you have one or more MIPS eligible clinicians on the participation list. What that basically means is it excludes those facilities that are purely MIPS facilities without any clinicians. Finally, three, the base payment incentives have to be on performance. In other words, they have to include some kind of quality measures. What are some of the benefits of getting this alternative MIPS APM scoring? Well, one benefit is that your cost category is reweighted to 0. And so because of virtue of participating in an alternative payment model, you do benefit from having your costs being weighted to 0 and the other 3 pillars of MIPS being adjusted accordingly. And the reason for this is, for example, if you're in an MSSP or a Medicare Shared Savings Program, which is a type of alternative payment model, they already assume that you have costs figured into your strategy. The final advantage is that you actually do not need to separately submit for a MIPS submission, because they will take your quality measures out of your submission from your MSSP, for example, if you're in that track, and automatically send it in for QPP analysis. So just for comparison, in 2019, the MIPS category, if you're just in regular MIPS, would be, as you can see here, 45% quality, 25% cost, and promoting interoperability 15%, and improvement activities 15%. When you reweight that for being in a MIPS APM, cost goes to 0, quality becomes 50%, and your promoting interoperability, PI, goes to 30%, and improvement activities goes to 20%. So cost is taken out by virtue of your alternative MIPS APM scoring. The other way that you could also become a MIPS APM participant and take advantage of that scoring is if you were in an advanced APM, but you did not meet the threshold to become a qualified participant. In that scenario, CMS has allowed those entities to actually take advantage of the MIPS APM scoring scenario. Here is the list of possible MIPS APM, and if you notice, it's a very similar list to what I showed you for the for the advanced APM model, because basically if you're an advanced APM but you did not make qualifying participant, you can then go into a MIPS APM scenario. The additions to this list are the MSSP 1 track, which is basically an upside-only Medicare shared savings track, and the one-sided models for oncology care. The other ones are essentially the advanced APMs for those who did not make the qualified participants. So essentially what I've showed you is sort of the spectrum of how we're going from fee-for-service to basically full risk. So the original model, or at least the model historically in medicine, was the fee-for-service. And now Medicare is transitioning that fee-for-service to a modified fee-for-service where it's more pay for performance. And that's exactly what MIPS is. As we move up the ladder, we have shared savings, which shared savings can have a upside only. And as you go further down, you entail more risk and go down that risk slider. Bundle payments is also in between because with those scenarios, you're taking possible shared savings, but you also incur some risk as well. And finally, when you are at the advanced APM level, you're incurring the full risk, but potentially the largest amount of possible bonuses. As you can see, CMS is clearly directing everybody away from MIPS and towards an advanced APM. First, of course, there is the 5% bonus for being an advanced APM, of course, and that does end in 2024. But you can see that MIPS, as you go along from 2019 to 2022, the bonuses do increase, but the risk also increases as well. So by 2022, we're talking about a possible 9% swing in possible penalties. And so there's a clear push towards having facilities go into an advanced APM scenario. And that concludes my portion of the presentation for the overview of alternative payment models.
Thank you, Ryan. That was excellent. We're now going to switch focuses and talk a little bit about what's happening in the Medicare Shared Savings Program. And we're fortunate to have an expert in that. Dr. Durand was formerly the Director of Accountable Care for Johns Hopkins Medicine. He served the past 3 years as Chair of Radiology for LifeBridge Health, where he heads up their value-based care and the LifeBridge ACO and CIN for the last several years. So I will now turn it over to Dr. Durand. Thank you.
Okay, is everybody able to see my screen?
It looks good, Dan. Yeah,
good. Okay.
It's a little small. Maybe you could blow. I'm not sure you can blow it up.
Okay.
Just go ahead.
Okay. All right. So thank you, Ryan, for that introduction. I'm going to be talking mainly about the Medicare Shared Savings Program, which, as Ryan mentioned, in the way that most folks have used MSSP, it is that track one upside only, but there are actually several options within the Medicare Shared Savings Program. So ACO can mean many different things, and within Medicare, it can mean a couple different levels of risk, and we're going to talk about that, and we're going to talk about how that has very, very recently changed in a way that I think will impact how radiologists can and will want to engage in these alternative payment models. Before I do that, I want to talk briefly about clinically integrated networks and value-based care and take some of those concepts that Ryan did forward a little bit more and talk about the strategy of these different organizations. Obviously we might have folks on the phone that work for a large health system that has its own ACO that they're kind of included in. We may have folks on the phone which is the majority of the ACR membership that works in private practice and might be making decisions about whether or not to be included. And so what I want to talk about is from the perspective of the ACO, how they view these Medicare programs and how they might view the participation of specialists and radiologists in particular. So to begin with, ACOs, accountable care organizations, that term gets used a couple different ways, right? If you're at like a conference or you're hearing it on the news. The original term accountable care organization came from the Accountable Care Act, or the Affordable Care Act, and it really is with reference to the Medicare what became the Medicare Shared Savings Program. Since that was created, all right, in the law back in 2010, and eventually launched as a CMS program, first as a pioneer CMMI initiative in 2011, and then eventually as a general program in 2013 on. Since that happened, people use the word ACO as synonymous with value-based care. And so in some areas, there are commercial contracts, right, that don't actually resemble the MSSP, but there are CINs that will engage in those value-based contracts, and they'll call it an ACO. So you got to be careful. The first question when you hear the word ACO is to clarify, okay, are we talking about the Medicare ACO or commercial ACO, right? And the commercial ACOs come in many varieties, and we can't have one talk about them because there's like 400 different types of contracts, and they vary by region and they vary by payer. The nice thing about Medicare ACOs, the reason it's worth talking about, is for two reasons. Number one, there's one program that can apply to in one way or the other to anyone on this call who wants to get involved in it. And the other is that in most regions, these commercial contracts will somewhat be modeled after the principles of this, just for ease of use. So clinically integrated networks, why do people do them, right? Why does the government allow them? Well, they let you might be in them because they allow you to get around certain Stark waivers around, keeping referrals tight and doing business together, but you can only do that if you're showing that you're actively trying to create clinical pathways, usually collaborating on capital investments like EHRs, and that you're doing all this to both improve the quality of care delivered to patient populations and reduce the cost. And if you're not doing that, you really wouldn't pass a conventional FTC test for clinical integration. Now, the ACOs, these Medicare ACOs, actually allow clinically integrated networks, if they form one, to, at least in the Medicare population, have a Stark waiver and be considered a clinically integrated network, which lets them contract jointly with Medicare. And typically, a CIN that has done that can then use that CIN board and create other contracts with other payers to accomplish similar things. And so you'll often see either a private practice association coupled with a health system, or sometimes a university faculty, and they create a clinically integrated entity that bridges the two of them, and that's their Medicare MSSP, and they may take all of those doctors or a subset of those doctors and put them in other value-based contracts. And so why are they doing that? Well, it really depends on the geography and the strategic reasons for doing that. We could talk forever about that. In many parts of the country, there's a real move towards trying to help employers save money in their employee populations. And so the one way of doing that is that the payers will create these value-based contracts to really try to focus the patient population in the practices of primary care doctors that are being rewarded to reduce the total cost of care or keep the growth of the total cost of care as modest as possible, while delivering quality however it's defined in that contract. So what are these contracts really doing, these value-based care contracts? Well, one way of thinking about it, and the way I think about it, is what I'm showing in the next two slides. So what we're trying to do here is take this conventional premium dollar, and in the current world, about 15 to 20%, probably way too much of it, goes to prescription drugs. Okay, about 20% goes to physician services in an ambulatory setting, PCP and specialists. Then there's other outpatient services such as surgeries, etc. There's inpatient services. There's payer operations. This last 15 to 20% of the premium dollar goes to payer operations, and if they can make, if the insurance companies can sort of squeeze that, and squeeze the other parts of the consumption of the premium dollar, they eke out profit. what the value-based contracts are essentially saying is if that primary care or a set of specialists can help control the overall spend, so they can be more judicious about using generics, they can be more judicious about using ASC instead of an inpatient surgery. In radiology, it typically means using freestanding imaging versus hospital imaging whenever you can. If you can control that premium dollar, then you increase the payer profit portion, right? And what the payers are saying is they will share a part of their profit essentially back with the provider, back with the clinically integrated network. And sometimes if the provider's doing novel things in order to achieve that, such as care management or utilization management, the payer may carve out some of their operations and free up other parts of the dollar. So they may say, you know what, as ChenMed does in the Southeast and East Coast of the country, the payers may say, we're not going to pay for a care manager. We're going to delegate those costs to ChenMed, and we're going to put them in a value-based contract where they share some of our profit. So the MSSP basically takes that same philosophy developed in mainly Medicare Advantage plans and Medicaid plans and applied it to the first time for fee-for-service Medicare. So what are these folks trying to do in an ACO or CIN? Well, they're basically trying to increase their share of the premium dollar. So they're trying to get more patients to come in, but in the current reality, if you just increase the size of the premium dollar and just increase the amount of patients going through the turnstile, so to speak, then you're going to have a high total cost of care, and the payers and the employers are not going to want to send their patients to you. And so in the new reality, in the CIN, you have to do both. You have to control the total cost of care, and if you do that, you will get access to other parts of the premium dollar, like the payer profits and potentially some of the payer services. And so your share of dollar can go up, particularly if you can decrease your leakage rate. And as long as you control the size of that overall dollar, the size of the overall spend, then payers and potentially even eventually the government in different mechanisms will flow you more patients, assuming that you've also done well on the quality measures. All right. And so the modern paradigm is something like there are these broad networks that everybody has, Optum, or in our geography here in the Mid-Atlantic, it's Care First, who's the dominant blue, and they have a very broad network, right? But if you're an employer and you approach them and you really want to control their costs, they will sell you access to a much more narrow network with various different tiers in it. And that's what this is all about, at the commercial side, is that these primary care doctors and a lot of the specialists that tend to be upstream of radiologists, they're really trying to deliver high value care so that they get more volume. Because if they wind up on the wrong side of the value equation, they're not going to get sent as many patients, going forward. It's harder for them. They'll be excluded from the networks of many of these narrow network products. So I'm going to talk briefly. That is the overall strategy of sort of CINs and what the word ACO means, and just sort of approaching it from the outside in, really from the perspective of a health system administrator or an insurance administrator, a government policymaker, or a primary care doctor, right? Bits and pieces of all those different stakeholders. Medicare ACO, here's how it works. It is a quality-gated MLR-based program. So what that means is the first part means that if you have certain quality measures that you're going to get judged on, and if you do poorly enough in them, you don't get any money no matter how much you save anybody, all right? And if you do really well in the quality measures, then if you save money, you'll get to save as close to 50% as possible, okay? That's the way this program works. In terms of MLR base, that basically just means we're looking at a certain portion of the premium dollar. It's not the full MLR, the full medical loss ratio, but it's about 65% of it. So it's all of Medicare Part A and Part B costs, and you're excluding drug costs, right? And you're excluding the administrative costs of Medicare, obviously. All right. So in order to get shared savings in an ACO, you have to do these two things. You have to reduce the Part A and B costs, and you have to reduce it by more than the minimum savings rate, which is different for every ACO, but tends to be about 2.5% of the total. And then you have to do well on the quality measures. And the quality measures are not really quality measures that specialists or radiologists would ever have picked. Okay, they're generally HCAHPS type measures around patient satisfaction, or they're very primary care focused measures that are either based on claims or they are based on EHR elements that are reported through something called the group practice reporting option, but specifically the GPRO that applies to the ACO program. The only metric that really relates to radiology on quality is not even truly a radiologist metric. It is the percentage of women in whom who meet the USPTF criteria for mammographic screening. So if they've had a screener in the last 24 months, essentially, it's based on the USPTF criteria, not the ACR criteria. It doesn't say anything about, whether that was done in an ACR center of excellence or whether it was a biopsy on a false positive. It doesn't get into any of that, what we deliver. It just gets into whether or not they were screened. And screening rates tend to be a little bit better in ACOs, but honestly not wildly better. So, which suggests that quality metric is not, a make or break thing for most ACOs. And again, when they achieve shared savings, the money typically, it goes to the ACO and they can distribute it however they want. They don't have to give it, everyone in the ACO doesn't have to get it. They can focus it just on the primary care doctors or just on the primary care doctors who performed well. And over the course of time, we've seen that because it's such a primary care focused program, more and more ACOs tend to flow the money preferentially to their primary care doctors, because it's actually such a modest amount of money that you wind up with that it's hard to get the attention, frankly, of most specialists to talk about a theoretical amount of money that is usually less than 3 or 4% of their take home. Whereas for a primary care doctor, this amount might be 10 or 15% of their annual salary. All right, CMS has restructured this program. So what most people have probably heard of is this MSSP program that I referenced here. You do well in quality, you reduce the cost, you get shared savings. All right. The majority of the ACOs in the country chose the track that Ryan referenced, which is upside only. In other words, I win if I win, and if I lose, if I overspend money, I don't have to pay anything. It's the joke's on Medicare. That's their problem. Okay. And there was about 500 ACOs that eventually popped up in this program, and what the government started noticing is that about 95% of them were taking that upside only, which makes sense, and only about 5% were taking the upside and the downside, and that got policymakers thinking, and they eventually said, listen, with the 2018 final rule that was made at the end of last year, CMS changed this so that every single ACO who enters the program will eventually have to take downside risk. So it used to be you could enter for a 3-year term and you could do no downside, upside only, and then you get a second 3-year term, so you get 6 total years with no downside. And there were even loopholes that allowed you to sort of create a new set of TINs if you wanted to and do a third term and do 9 years, okay? CMS has closed all those loopholes, and the only ACO programs that exist today are the following. So I'm going to go down 2 slides here. There are these 5 different levels, okay? And you can enter at whatever level you want, but you can only spend 1 year at a level before you get ratcheted up to the next level. So in other words, if you formed an ACO today, as you can see on this screen, the first 2 levels are that downside only, and they have a lower percentage of savings than you used to get. You used to have no downside, and you get 50% of the savings. And as you took more risk, you could get up to 75% of the savings. Now, you get only 40% in those first 2 years. And then your third year, it's a 5-year agreement, so you have to go up. So if you enter for 5 years, you know that from year 3 forward, you're taking some kind of downside risk. In other words, at the end of the year, your ACO could wind up having to pay Medicare back money, which is like every ACO executive director's worst nightmare, because there are millions and millions of dollars at risk here. If you have 20,000 ACO members, your total medical spend, will probably be over $200 million in most parts of the country. And so if you wind up overspending by 5%, that's $10 million that you got to find out of budget to pay the government back. So this is, really going to give people pause. That's one thing, is that you have to take risk now. The other big thing is something a lot of news agencies miss, because, but I think it'll start coming to the fore shortly, is that what defines the upside risk in the middle column here is different. If you notice, it's a different definition than the downside risk, and it's a nuanced difference. So your upside risk is determined by what they expect to be spent in the total healthcare of these patients. Okay, so this total patient population cost $200 million last year. We expect it to cost $202 million this year, something like that. But the downside risk is either that some percentage of the total medical spend in the benchmark, and quite a bit lower, right? So the upside is like 10% of the benchmark. The downside is just 1, 2, or 4% of the benchmark. But if you look there, it also says 4% of ACO revenue. So what are we talking about there? Well, if you have an ACO and it consists of every specialist under the sun, like in a health system, there turns out not to be a lot of a difference between your benchmark for your Medicare population and your total Medicare revenue. In fact, your total Medicare revenue might be quite a bit higher than the benchmark of your ACO population, because your ACO population is defined as those patients who have received most of their primary care through your ACO doctors. So if you have an ACO that has a small percentage of primary care doctors, right, then your benchmark will be much smaller than your total ACO revenue, and you'd be at risk for a lot, right? Conversely, and this is what I think will shape the future of the program, if you excluded all specialists from your ACO, your MSP ACO, and focus the members of the ACO to be primary care only, then you'd have a high upside, like high potential gains, and you'd really have much lower downside because the primary care revenues are so low, right, compared to the total amount spent in those patients. And I'll just go back to here. What I'm saying is this small dark band in the premium dollar here, all right, on the that shows the PCP revenues, that is actually going to turn, you'll be some fraction of that for your downside, which would be a very small downside, but the upside would be a larger fraction of the full dollar. So what does this mean? It basically means that the ACO program had historically been this more inclusive program where people could have an upside only experience and do a lot and fulfill a lot of their quality reporting for APMs and et cetera. And now you have this change where a lot of ACOs will probably go away because those that aren't performing are unlikely to stay in the program, where not performing used to mean you still fulfill some of your MIPS APM requirement, but you just don't get any money. But now it means that you might have to pay the federal government back $5 or $10 million. That's a very different set of decisions. So I think you'll see a lot of ACOs dissolve, and they'll go, and the various different physicians will either go into narrower primary care ACOs, or they will go into more MIPS type approaches to handle their macro requirements. And the ACOs that form going forward are certainly incentivized to be much more focused on primary care and not include specialists because of the way that it impacts that downside risk that they have to carry by the third year. So again, there are a lot of details in the program, so I'm going to stop now for questions. But just trying to get the broad strokes of what's gone on with Medicare ACOs and why, at least I think, that this latest rule kind of changes the calculus for any specialist, but particularly radiology groups to participate.
Great, thanks Dan and Ryan for those presentations. We really appreciate your expertise in this area of payment models. The vast majority of radiologists definitely participate in MIPS. We have very, very few of our members who are actively participating in alternative payment models. But as Ryan said, I think that there's a very clear push towards this type of risk-based payment from CMS as well as from commercial payers. And we're seeing that in a lot of our markets and hearing that from some of our members. So I really think it is important for us to understand how these programs work and think about what we can do to prepare our practices to be ready for risk-based payments and more population-based payments. I think now we're going to open it up. We're going to start taking questions from the audience. Greg and I have some questions as well that we can intersperse here. But if you have a question in the audience, either raise your hand or you can type it in the chat box. I do want to start with the first question. We asked Dan and Ryan specifically to be presenters because both of them their institutions participate in alternative payment models. So if they would just briefly, I think it'd be useful to hear how the radiology departments in their institutions participate, how they get involved, and just share their experience in their own institutions.
Sure. I mean, I'll jump in to get some of the low-hanging fruit. But you know, there's that one metric I talked about, which is breast cancer screening, and so we've definitely seen an increase for our health system to want to get the patient screened, and then also make sure that the evidence of screening gets into the chart, because it's not enough just to have the Medicare claim showing the patient got the screen, but you have to show that the primary care doctor put it in the medical record and read it. And so within our health system, that's pretty easy. They go to one of our access points that winds up in Cerner, because that's our EHR. But we've also done a lot of work with one of the predominant group in Maryland, which is Advanced Radiology with RadNet, to make sure that for both of the ACOs that are in our CIN, we actually have two separate ACOs, that we know anyone that has a claim, right, where we see the claim and we don't see the report got into the EHR, we have quality staff that work with those outside or partner practices. It's not part of our health system, but they're closely affiliated, to make sure that data goes where it needs to go. It is largely a back office thing. It's not something individual radiologists are deeply involved in. One thing that individual radiologists have been deeply involved in is the mammothons that we hold toward the end of October, which is Breast Cancer Awareness Month, to get the word out. And it's not about the ACO, it's about, you know, women and the need to detect breast cancer early. But the existence of this value-based program and the fact that I can tie some revenue to that performance, that metric, has let me get my health system to buy ads on NBC and put them out on Facebook and staff these breast care centers into the evenings to do these mammothon events. So it's more about the value-based program creates a business case to invest in these kinds of population health activities.
Lauren, I'm gonna just add to this, because the college has done a number of activities that will hopefully be leveraged by our members to participate in these value-based contracts and organizations. One is we do have the RScan initiative, which is basically the right test at the right time for the right patient. That's something that's we're finding valuable, especially in my organization, which is also in a risk-based contracts with commercial payers and with Medicare, making sure that the patients are getting the right test and working with your referring ordering providers and referring clinicians that the test is appropriate is vital to these organizations. Wasted studies is a large bucket of money, and we certainly have the option of controlling that as radiologists. Another mechanism is clinical decision support, the authorized use criteria. That's part of the PAMA legislation, and theoretically will start in 2020 with penalties happening in 2021. Again, this is a software program that can be loaded in an EHR that has recommendations created by multiple specialty societies, including the college, on what is the appropriate test based on a number of clinical scenarios. And those are things that the college offers its membership, and also our registries. Even though, Dan and Ryan spoke very clearly that there aren't really quality measures related to radiologists in these types of payment models. However, that doesn't mean you can't prove your value by collecting quality measures. Our registries have a large number of measures that could be quite vital to these organizations, maybe not in the payer contracts, but vital to providing appropriate care to their patients. And so those are just three mechanisms the college has worked on. They have applications both in MIPS and in alternative payment models. And I do think radiologists have to take a lead in promoting their value in these organizations, even if the organization itself doesn't have to submit quality measures. So I just wanted to throw that in there.
I completely agree. I completely agree. And part of the issue for us, and so at Einstein, we are part of the MSSP track 1, so the upside only track of MSSP. And as both Greg and Dan have alluded to, there aren't that many measures specific to radiologists. However, that does not mean that we don't participate in a lot of these quality measures, whether it's registries, as Greg mentioned, or clinical decision support, because these are ways for us to show value. It's just interesting, though, when you actually look at the participation of the radiologists in the MSSP1, most of those measures, if not all of them, are really related to primary care. So are we actually actively participating? At this point, not. But we still do these quality measures in order to prove our worth, even though it may be outside of the scope of MSSP.
And I would add to that, it's vital that we all decrease variability care, and it doesn't matter what specialty you are. But radiology has a number of initiatives that have aimed at decreasing variability, including our standardized reporting templates, our standardized lexicon, for example, using PI-RADS and TI-RADS and lung-RADS. And many of you may be aware or may not be aware that both Radiologic Society of North America, the ACR, and the ASNR are working on a common data element initiative, which is really structured language, how to describe many different pathologies, so that we're all on the same page and we're giving information to our clinicians that's consistent across the board. And those are excellent ways to decrease our variability.
While we're talking about tools, I wanted to mention one other tool that the Neiman Health Policy Institute has developed to help radiologists in these types of bundled payments and risk-based payments. The Icet, which is the inpatient cost. Oh goodness, what is it? Yeah, it's a database of what in your specific area radiology services should be valued within a bundle. So if you're in the situation where your commercial payers or your Medicare contracts are trying to get you to accept bundle payments, that's a tool that's free. You can look up. It's a good resource to see what about the payment should be when you're negotiating, so you know that you're not getting too much or too little.
Yeah, and Lauren, since you brought it up, that's about bundled payments. And Dan brought up an excellent point that you're very likely to see organizations start narrowing their risk by isolating primary care doctors into accountable organizations and excluding specialists. What are the opportunities for specialists, and where do you think radiology fits into those? Because it might not be accountable care organizations, but there are certainly other types of APMs that Medicare offers. Can you go into those a little bit?
Sure. Yeah. I mean, I think everything you just referenced, right? All the tactics you just referenced should allow radiology groups to demonstrate to a CIN or a payer or a health system, we offer tremendous value in what we do, and we also help you control the total cost of care, right? So we're helping you get the right test at the right time. We're helping, we have breast recall rates that are acceptable. We're not calling everybody back. Where our biopsies have very few false positives. All these things I've noticed, in dialogues with CINs on both sides of the table, that stuff people listen to it. And I think what you said is key, that whether you're talking about the Medicare programs or you're talking about the commercial contracts, it's more about value and demonstrating value to appeal to the CINs and the people that are upstream of us, primary care, et cetera, to demonstrate that if you send patients to us, we're gonna be aligned with you, and we're not going to overdo it on the imaging. And if we image, we're going to image appropriately, and we're going to not overcall pathology just to hedge. We are going to be, as precise as we can. We're going to use the right structured templates, the right language, and the right follow-up tests, not necessarily the ones that are the most lucrative follow-up tests. Really addressing all those things head on, reporting on them, agreeing to track them. I think those are all traits of a radiology practice that has a future in a world of narrow networks, right? And yeah. Conversely, if you don't use those registries, or don't understand, that they even exist, if you're out there just practicing the way folks have always practiced, and you're not able to, even if you're doing a great job, but you can't prove it because you haven't lent your work and your reports the structure that it takes to prove that you're decreasing variability.
That's a great
I think
point.
You're really at risk. I think you're at risk from being excluded from these networks. Yeah.
Yeah, and not only that's an excellent point, Dan, is that the fact is we are in an era of proving ourselves with data. We're in a data-driven society, and if you think you can sit back in these organizations and ride on the coattails of primary care or your organization in general, I think that's probably very short-sighted. And I would interject that when these organizations come up against a wall, for example, they don't make shared savings, or their care coordination dollars start to dwindle, it's very hard to actually save money without putting those care coordinators out there and those managers out there. And they may need revenue from other aspects of their organization that could be somebody who doesn't appear to be proving value. So I just caution radiologists of sitting back and watching their organization get them through these programs, because I think that you make yourself a target when the going gets tough. So.
Greg, you had asked if there were any other options other than ACOs for specialists and radiologists to participate in APMs. One I want to mention is, I think Ryan mentioned as well, is the BPCI Advanced, the Bundled Payment for Care Improvement Advance. It's a new alternative APM started last October, and it is one that is a little bit more geared towards specialists than some of these other ACOs that are predominantly primary care focused. That particular model has 29 inpatient and 3 outpatient clinical episodes, and some of those are relevant to radiologists. There's a stroke, there's pneumonia that certainly would have imaging, some GI hemorrhage, and some ones that interventional and diagnostic radiologists could be a part of. So I think some of those opportunities for specialists are expanding. BPCI Advanced has had a pretty big participation so far. It's just in the early stages. I think there's a couple of radiologists around the country that are having some participation in it. But that's one alternative to some of these ACOs. And I think we will probably start seeing some more that are episode-based that radiologists may have a chance to be involved in.
Yeah, and a point of clarification, many of you might have heard of the Bundle Payment for Care Improvement Initiative. It was a pilot project that started many years ago, and then it sunset. And now it's been reinvigorated into a new advanced APM that's more clinical. It's more focused on clinicians and instead of organizations. And it allows physician groups or hospital networks to sign up. And Lauren, I think you did a great summary of what it was. And all the tools we've mentioned would be also extremely valuable if your organization or any of your specialists are participating in BPCI Advanced as well.
Yeah, and I think so. That's a program that I know a little bit less about because it's not in the state of Maryland doesn't allow it. But one of the good things I think about that program from those who are participating is that one of the challenges of CDS, right, is that you're talking about all these different criteria for every test, and getting it hard is sort of getting it right is very hard, and it's kind of mind numbing how many different scenarios there are. And I think the nice thing about that a lot of physicians are liking about BPCI is that you can focus your whole value chain around specific conditions and episodes.
Yeah.
And you can just really get it right, kind of like the work. It's like the difference between ACR Select, which is a lot of different things, and it's very helpful, but it is challenging to go across all those different scenarios versus really getting the lower back pathway perfect, right? And that's what I've heard, that people feel like you said, it engages clinicians a little bit more because it's about the specific scenario.
Yeah, and we've found that, Dan, we've found that in my own organization, even though we're not in BPCI Advanced, we are entering bundle contracts with our commercial payers that we actually built our own bundles. And that's one of the reasons, exactly what you just said. We feel like we have more control. There's more teamwork around a specific goal as opposed to nebulous population health. This is a specific target on how to really advance your care path. So I think you said that really well. And I do think that that's going to become quite popular with specialists. It'll be interesting to see what organizations do when you have both an accountable care organization like a Medicare Shared Savings Program and a BPCI, because then again, it gets fairly difficult to figure out where the shared savings are going, and it'll be an interesting conundrum that's been quite written robustly about in the literature. But we're really, at the early stages of figuring out how all this is going to work.
The other thing about BPCI that is a nice thing to look at is that it allows organizations to take a smaller sort of a chunk and see how the risk-based actually works, because all these advanced BPCI can be used as building blocks to build yourself toward being a qualified participant. So that's another way to look at it as well.
That's great. That's a great point, Ryan. I mean, you really can think of every single one of these models we're mentioning as capitation in some way. It's either capitation at the disease level, the procedure level, or the population level. And you can look at BPCI as a bundle, a much smaller bundle than what an accountable care organization will be looking at. In a simplistic way, there's clearly advanced nuances in that, but I think in a simplistic way, these really could be used as a building block towards population health.
So Dan had mentioned in his presentation that there were some changes to the MSP program that were forcing two-sided risk. Health and Human Services Secretary Alex Azar made a comment about how he would prefer to have many fewer participants in ACOs and have more two-sided risk. What do you guys think is going to be the impact of these regulatory changes of forcing people into risk? Do you think a lot of people are going to jump out of the APMs, or do you think they're going to suck it up and take on the risk? And how do you think that's going to affect some of our radiologists that are in multi-specialty practices that are in that one-sided risk like Ryan's?
Yeah, so this is Dan.
Yeah, I think Dan hit.
Yeah, sorry, go ahead.
No, go ahead, Dan. I was just going to say that I think you made some very astute points about that. There's going to force a lot of people to do some hard thinking about whether it's a good idea to stay in, and the way those losses are incurred really does seem to encourage, as you mentioned, whether you want to keep specialists in.
Yeah, I think you'll just see a lot of. I think it's a given that you'll see far fewer specialists in, and thus more participants in MIPS. And I think that the big question is, if you get out of the ACO game as a health system, what do you do with where do you put the primary care doctors who are doing well within it? Because it's like there's a bell curve, right? So if I got 200 primary care doctors in my current ACO, some of those guys are doing really well, and there is a subset that I would feel comfortable taking downside risk on. So that I think is what you'll see. I think you'll see maybe the number go from like 500 down to like 250, and those who stay in will narrow their network quite a bit. About half, probably the bottom half in terms of total cost of care. They'll keep those primary care doctors in, and in the independent physician networks, I think you'll see people really jump into these low revenue ACOs, which I really didn't cover in my talk. But if you're a low enough revenue ACO, then like you're small enough, they'll let you do this this upside only track, and that's really designed for very small ACOs, which tend to be IPAs of just 20 to 30 primary care doctors, and that's the group that they're targeting there. And the reason they're okay with that, like why are they letting them take upside only? Those guys, that subset has been the best performer of the existing program. So the large health systems have not done as well, but these smaller groups of primary care doctors have done pretty well. And so they've created this low revenue option. But again, if you look closely at it, it's really designed for primary care.
Yeah, and I want to add something that Dan just brought up in my mind and that is, if we do see, and I think Dan's absolutely right, if we do, and Ryan brought this up, if we do see an exodus of specialists from ACOs or shrinkage of ACOs that focused on primary care, our radiology colleagues that are currently in these groups, and they may be academic practices, faculty practices, or multi-specialty groups who are not currently getting used to submitting quality measures, for example, into the registries or however they want to do it, they could be thrown into MIPS without any tools or any experience. So again, I think it behooves every radiologist in this country, regardless of what kind of practice setting you are, to get used to collecting data, submitting data, understanding where you lie in these performance programs. And if you get thrown into MIPS because your ACO decides it just doesn't want specialists, you're prepared, because otherwise you're really going to be behind the curve.
Greg, I think that's a great point. And one other thing I want to add to that is that one of the changes in the MIPS rules for 2019 is that you can use more than one submission mechanism to submit your quality measure. So if your whole group, your whole 10 decides to leave the ACO and are now in MIPS submitting quality measures, in the past you had to only use one form of submission. So maybe your group would submit mostly primary care measures via EHR or something like that. But now in 2019 you can use two. So maybe your radiology measures from a QCDR are actually, you perform better than some of those primary care measures, and that's a really good way for your group to demonstrate value and show your contribution if you can contribute 2 or 3 of the MIPS measures and improve the score for your whole organization.
Yeah, great point, Lauren. I think
all right, guys. We're getting close to the top of the hour here. I want to especially thank Dominic and our staff who organized the webinar today, and our speakers, moderators, and everyone who joined us tonight. This will be recorded. It will be accessible on the website, I think, in a couple of days here. And our email address is always available. If there's any questions that people have later or experiences you want to share, feel free to do it. Thanks to everybody, and have a good night.
Thank you, Lauren. Take care.
Thank you.